Hi everybody, my name is Tyler Maxwell. I'm a PJY1 pharmacy resident here at Stony Brook University, for those of you that don't know me. And we are going to do this journal club of the use of Tocilizumab in patients with COVID-19. This is going to be round 2 of our journal club. Unfortunately, I did not hit the record button the first time. So I am going to do this journal club real quick so that we can post it on YouTube and anybody can view this information if they want to at a later time. So again, the journal club today is going to be on the use of Tocilizumab. Tocilizumab has gained a lot of attention recently for use in COVID-19, especially patients that are in a more severe state and they have an affiliated cytokine storm. And so the journal that we're going to be looking at more specifically is the effective treatment of severe COVID-19 patients with Tocilizumab. Our background on this is a little more intensive, and I think that's because Tocilizumab is a little more complex of a drug, and so it's really important to get an adequate background of this medication so that we can understand what role it does play in this therapy and then how it is working in these patients. So on the virus, the SARS-CoV-2 virus is a positive sense single-strand RNA virus that has become known for having mortality rate that ranges depending on age and location, but also the average is about 2.9% mortality. The virus does spread through respiratory droplets, and it actually can begin shedding and start its contagious period before the patient does begin showing symptoms of the viral disease. This is usually about 2 to 3 days before a patient begins showing symptoms. And because it's spread and contagious so fast, it's led to a widespread infection in the world and the pandemic situation that we're in right now. As of yesterday, there's been about 100,000 deaths globally, with about 1.5 cases that have been confirmed worldwide. In New York City alone, I actually got an update on this one. There are about 8,000 deaths as of today, and that would be as of 4/10. Although it has been discussed recently, I've heard that the rate of new patients that are confirmed may not be increasing as fast as it has been in the past. We're still not at our peak of infection here in New York, and so that number still is going to be rising for a little bit, although we may be approaching that peak. Infected patients often are going to present with a shortness of breath, a dry cough, symptoms of an upper or lower respiratory tract infection. And then as the disease progresses, we're going to be able to see an opacity on the chest CT or the chest X-ray. This is going to be accompanied by increasing O2 demands and lab abnormalities. A lot of our patients, we see an elevation in D-dimer, PC intervals, and fibrinogen, and this indicates they're entering into a hypercoagulable state. Because there's so much we're still learning about this virus as we continue to treat these patients, it leads to really continued questions about the appropriate therapy. So whether it's anticoagulation, ACE/ARB therapy, NSAIDs, we are learning more every day on what we really should be treating these patients with. Patients that really succumb to this disease often are going to develop ARDS, or acute respiratory distress syndrome, and or a cytokine storm that is going to contribute to the breakdown of the alveolar sacs in the lungs and prevent patients from oxygenating their organs. Acute respiratory distress syndrome, or ARDS, is really defined as the rapid onset of respiratory failure due to systemic inflammation, trauma, or in this case, severe infection. This is often accompanied by the presence of bilateral infiltrates and is associated with significant morbidity and mortality. Hypoxemia is defined through the ratio of the partial pressure of oxygen to the fraction of expired oxygen. So this is the PaO2-FiO2 ratio. The Berlin criteria classifies the PaO2-FiO2 ratio. If it's between 2 to 300 millimeters of mercury, this is going to represent a mild ARDS. 100 to 200 millimeters of mercury represents a moderate disease, and then anything under 100 is going to be a sign of pretty severe ARDS. ARDS is typically going to be treated through a combination of O2 therapy, IV fluids, and then treating the cause of the respiratory distress in the first place. And in this case, that would be the infection. In addition to causing ARDS, COVID-19 has been able to produce a cytokine storm in infected patients. So according to the National Cancer Institute, a cytokine storm is a severe immune reaction in which the body releases too many cytokines into the blood too quickly. In a cytokine storm, the immune cells are going to release a lot of different inflammatory mediators. This may include interferon gamma, IL-1, IL-6, TNF-alpha, TNF-beta. And so there's really a lot of cytokines that can go into the cytokine storm. While in ARDS, the cytokines are going to lead to vascular permeability and inflammation of the lungs. This inflammation is going to cause damage to the alveoli, which is going to increase the space between the oxygen transfer membrane in the alveoli and the surrounding capillaries, which is going to worsen the gas exchange. This results in many of the symptoms we see commonly in our COVID-19 patients, so shortness of breath, increased respiratory rate, decreased oxygenation, and possible respiratory failure. IL-6 is one of these cytokines that is involved in inflammation and works by activating T cells, secreting immunoglobulin, and proliferation of hematopoietic cells. Tocilizumab is a medication that competitively binds both soluble and membrane-bound IL-6 receptors. This inhibits the binding of native IL-6, and by inhibiting this, it helps reduce inflammation that might be caused by IL-6. So IL-6 is found normally within our bodies between 0 and 16.4 picograms per milliliter. But as I'm sure many people have seen, in a lot of our patients that have COVID-19, they may have IL-6 levels above 100 picograms per milliliter. So it's pretty profound. As many patients do have this increased IL-6 with concomitant ARDS at the same time, it's been theorized that tocilizumab may be beneficial in the treatment of ARDS during a COVID-19 infection. So before we get started into this journal, I want to talk about some of the clinical trials that have been done on tocilizumab itself and where it's been. I'd like to actually first look at number 1 down here. It's a little out of order. This first study is a study of tocilizumab for the treatment of chimeric antigen receptor T-cell induced cytokine release syndrome. And so put shortly, this is going to be tocilizumab for CAR T induced cytokine storm. And CAR T is a cellular therapy. It's often used in cancer, where T cells are removed from the body and they are modified with chimeric antigens to be more specific for an antigen on T cell tumor, or not on T cells, but on tumor specifically. One of the side effects of this CAR T therapy is a cytokine storm. And so tocilizumab actually has been used in the treatment of cytokine storm before. Specifically when it's secondary to this CAR T therapy. In this study, they used tocilizumab at 8 milligrams per kilogram, and they saw reductions in clinical improvement, reductions in fever and clinical improvement in a lot of their patients. Now I'd like to move back up to our bullet point here, and the reason I didn't put a citation here is because this is sort of a conglomeration of a few studies. So the clinical trials for tocilizumab took place over a 24-week period. And the most commonly reported infections or adverse events were upper respiratory tract infections in about 5 to 8% of our patients. And these included more like a pharyngitis and runny nose. And then serious infections when tocilizumab was given between 48 milligrams per kilogram were reported at 4.4 and 5.3 serious events per 100 patient years versus 3.9 serious events per 100 patient years in our control group. The studies concluded that overall the rate of infections in the exposed group of patients was consistent with the rates in the controlled groups in these studies. Now, why this is important, tocilizumab does have 2 black box warnings, one for the recurrence of pneumonia, and then one for severe infections. And so in these studies, I think it's important to remember that tocilizumab was not being used for a cytokine storm as a one-time dose. It was used over a 24-week period, and usually it's dosed every other week. And so they may have been taking tocilizumab for a long duration before they were developing these infections. And so even then, within the studies, the rates the studies found were not, or they were consistent with each other. There wasn't a huge difference between the rate of serious infection. And so while serious infection, it definitely is something we should be concerned about because it is a black box warning for this medication. The rate of these serious infections is pretty low with tocilizumab. The next thing I'd like to talk about here are some of the clinical trials that are currently ongoing with tocilizumab. And so we do have tocilizumab versus placebo or standard of care. We also have a few other drugs that are starting to be studied, such as anakinra. Anakinra is an anti-IL-1 medication, and so this is another cytokine, so they are going to be looking at tocilizumab versus anakinra. And then we also have some other medications such as ciltuximab down here. Ciltuximab is another anti-IL-6 medication, and so it'll be interesting to see when these studies come out, what the data does say. A lot of these studies, I believe these 3 are going to be, are already recruiting patients. 1 and 2, I don't think have started recruitment quite yet, so they may be a little bit longer until that data comes out. Excuse me. So why this study? Patients with COVID-19 often develop respiratory failure and ARDS, and many of these patients have elevated IL-6. So tocilizumab has been studied in the past in a cytokine storm as a component of the CAR T therapy. So this study was done to observe the role of IL-6 in COVID-19 and evaluate the efficacy of tocilizumab treatment in patients with severe disease. This study was funded by the Department of Science and Technology of the Anhui province in China. And this was a retrospective observational study. Patients were recruited from the first affiliated hospital of the University of Science and Technology of China. Again, this was in the Anhui province, and they were included in the study if they were severe or critically ill. Now, this definition came from the Diagnosis and Treatment Protocol for the Novel Coronavirus Pneumonia, the 6th edition. I have their criteria right below. So severe patients had a respiratory rate over 30 breaths per minute, an O2 saturation under 93% on room air, or a PaO2-FiO2 ratio under 300. Now, it's important to remember that for this severe criteria, this was an either-or situation. Patients did not need to meet all 3 of these criteria. As long as they met one of them, they were classified as severe. Our critical patients for this study did have respiratory failure. They had ventilation, shock, or organ failure requiring ICU admission. And then all of our patients did have informed consent. For this study, all patients did receive a CT chest scan prior to initiating the therapy and had a diagnosis of SARS-CoV-2 performed by PCR. The standard of care was given to all patients, which is lopinavir, methylprednisolone, oxygen therapy, and other symptom relievers. Now, I believe that this lopinavir was actually given as Kaletra, which would be lopinavir ritonavir, because that's a more common therapy that has been used in our COVID patients. But in the documentation, they only mentioned lopinavir, so I'm not entirely sure what they were giving as their standard of care. The intervention here was tocilizumab, is 400 milligrams IV as a one-time dose. Most of our patients only did receive that one-time dose. There were a few patients we'll get to in the results that received more than one dose. Clinical features for each patient were recorded at baseline and then also following the administration of tocilizumab for a 5-day period. Statistics were recorded as descriptive statistics, so they were recorded in this study as a means plus or minus a standard deviation. And now we'll get to the results. So a total of 21 patients were entered into the study. 18% of them, so the vast majority, only received one dose of tocilizumab. Whereas 3 patients, so about 15%, did receive a second dose due to the development of fevers within 12 hours. But that was a small percentage of the patients. The mean age of our patients was 56.8 years old, and most of our patients were male, about 85% of them. Around half of the patients in the study did have a past medical history of diabetes. And when we look at this clinical presentation, it's pretty consistent with what we see here in our COVID-19 patients. So 100% of our patients did have a fever. Most did have a dry cough, and then there was some fatigue, dyspnea, and nausea as well. Now, 17 or 81% of our patients were classified as severe. So real quick, I'd like to go back up and see what that definition of severe was. So severe was a respiratory rate of over 30 breaths per minute, an O2 saturation under 93% on room air, or a PaO2-FiO2 ratio under 300 milligrams. What I'd like to mention here is that these severe patients were not ventilated and did not require ICU admission. They were just severe. Our mean IL-6 expression was 132 plus or minus 278. So one thing when I read this mean expression, the standard deviation is greater than the mean. When you have such a large standard deviation, it means that there was a large variation in those. So even though our mean is reported as 132 for IL-6, the variation in these IL-6 values likely was pretty large. And so there could have been quite differing numbers here. Our primary abnormality on chest CT was a plaque-like ground glass opacity and focal consolidation, and then about half of our patients needed heated high-flow oxygen therapy, and around a third needed nasal cannula. Lastly, I mentioned how many were ventilated, invasively ventilated. Only 2 of these patients were requiring invasive ventilation. Now, one of the interesting things about this study is this study didn't actually have clinical endpoints. They only recorded clinical findings because this was a retrospective study. So I'd like to draw our attention here to the lymphocyte and the CRP rows of this table here. Lymphocyte percentage is typically 20 to 40%. In this study, they recorded a normal range is 20 to 50%. Before tocilizumab was given, the mean lymphocyte percentage was about 15.5. This is below the normal reference range. Things that can cause a low lymphocyte percentage would be a viral or really any kind of infection. And then about 5 days after the tocilizumab dose, the mean did come to a normal reference range. This could be a sign of resolution of the infection. The next thing I'd like to point out is CRP, or C-reactive protein. A normal reference range for CRP is between 0 and 5 in our normal patients. Now, in these patients with COVID-19, the mean was 75.06, which is a pretty high CRP number. Now, after 5 days, or 5 days after the tocilizumab therapy, this reduction was pretty drastic and reduced down to 2.72, so again within that normal range. Body temperature did return to normal on the first day after treatment in 100% of our patients. O2 saturations improved markedly over the 5-day study period. And then oxygen therapy requirements were lowered in about 75% of our patients. CRP did return to normal in 84.2% of the participants, and chest CT scans showed pneumonia absorption in 90% of the patients, with a mean hospital stay of 13.5. At this point, I'd like to pull up the study real quick. And so I think the study does a really good job of graphically showing what these values, like how these values actually were recorded. So CRP had a pretty wide range on the initial day 1 before tocilizumab was given. Once tocilizumab was given, we did have a sharp decrease in the levels of CRP. And by day 5 of treatment, almost every patient had returned to normal values of CRP. When we look at temperature, we had the same thing. There was a drastic decrease after day 1 of treatment from tocilizumab being given, and then all patients remained normal over the 5-day follow-up after the tocilizumab dose. These graphs down here are a representation of oxygen concentration and saturation. So on the left-hand side, we have a concentration of oxygen inhalation. This would be our fractional inspiration of oxygen. So on a ventilator, we typically want to see patients closer to around 40% of fractionally inspired oxygen. So as we can see, one patient specifically was needing quite a bit of oxygen, and patients were requiring overall a greater concentration of oxygen. For the 5-day period after tocilizumab was given, we do see a reduction in this oxygen requirement when we were given to patients, which is good to see. On the flip side, we look at oxygen saturation and how well are our patients perfusing. So we want to see numbers around 96. Anything above 93 is really what we're aiming for. But in general, you can see that these patients did have an increase in their oxygen saturation requirements after tocilizumab was given. So graphically, I think this study did a good job of showing that. Unfortunately, it is hard to compare numbers with no statistics. So some of the limitations that the study authors defined were that this study was a small sample size, only having 21 patients, and it was a single center observational study. So unfortunately, there was no control to look at when they were looking at their data. The authors did conclude that throughout the duration of the study, there was no adverse reaction observed, and clinical symptoms improved in all their patients. So they concluded tocilizumab is an effective treatment option and provides a new therapeutic strategy for this novel disease. So my critique for this study, I think in general for this study, it's hard to make extrapolations on an observation study, and especially a study that had such a small sample size as well. So we'll start with our first bullet point. The sample size of this study was only 21 patients. In any statistical analysis or statistical literature, the more the better. So as you increase the number of patients, you do see that your statistical analyses gain power, and you can make those extrapolations for your patients and be able to make more statistical analyses and more claims in that study. So with a patient or a sample size of only 21 patients, it is hard to make any statistical analyses or claims on these results. This study is also a retrospective observational study that evaluated outcomes in these 21 patients. So due to the observational nature of this study, there wasn't a control group that was ever put into place. The purpose of a control really is to observe any changes that are due to the treatment rather than anything that may have been made due to outside factors in these patients. And so because there was no control group in place during this study, it's nearly impossible to draw anything meaningful from this study, because we don't have any way to say that the improvement in these patients wasn't just due to a random chance or something else that was being done in the hospital, some other treatment that we may not have known about. So it is hard to prove that any of these improvements were specifically due to the tocilizumab. So this study only reported descriptive statistics in the publication, although these are really fun to look at, and the graphs show a lot of trends that give great ideas for future studies. It's very hard to extrapolate and generalize any data from these descriptive statistics. So any significance can't be obtained from these conclusions, which is hard to make any claims about as well. The next thing I'd like to point out is the typical dosing of tocilizumab is done by weight. And so the manufacturer recommendations and past studies have actually found that the normal dosing is 8 milligrams per kilogram per dose, with a maximum of 800 milligrams per dose. In this study, the hospital chose to use a one-time dose of 400 milligrams regardless of patient weight. So it's pretty unclear to me why they chose this single-strength dose. Why did they use 400 milligrams when all the past studies that have been done, including the study on cytokine storm and the cytokine release syndrome, chose 8 milligrams per kilogram per dose. So I don't know how they come up with this 400 milligram one-time dose. At this point, I want to draw your attention back up to some of these clinical trials that are in progress right now. So one of the good things that I do see coming out in the future, again, here we're a report of all the clinical trials involving tocilizumab in the future. As you can see, almost all of these clinical trials are evaluating tocilizumab at 8 milligrams per kilogram per dose. Only this one in the middle here has the tocilizumab 400 milligrams IV times 1 dose. Everything else is using 8 milligram per kilogram, and that's because that's what the manufacturer recommended, and that's what the studies have shown work in the past. And so again, I don't know where this 400 milligram came from. Unfortunately, right now, this is the only data we seem to have in our COVID patients. But it'll be interesting to see where that 8 milligram per kilogram dose kind of shows up in the data. So the patients that were enrolled in this study also don't fit the clinical presentation of our patients here at Stony Brook. Severe patients, again, were defined as having a respiratory rate over 30, an O2 sat under 93, or a PaO2 FiO2 ratio of under 300 milligrams. So indicating acute lung injury. Only 2 of these patients were requiring invasive ventilation. Here at Stony Brook, as of today, 4/10, we have 101 patients on a ventilator. And so it's kind of hard to extrapolate this data to our more severely ill patients. Though I do think it would have been really nice to see that data and see how the tocilizumab results and these trends that they were able to show in the improvement of their patients, to see if they were able to see that in our more severely sick patients. And so something I'm hoping to see in some of these clinical trials that are coming up are the number of really severely and critically ill patients that are requiring mechanical ventilation. It'll be really interesting to see where that data comes from and how this works in our more critically ill patients. And then lastly, one of the clinical presentation characteristics that the authors looked at in the study was the improvement of pneumonia on CT chest scan, or the absorption of pneumonia. They reported about 90% of the patients did absorb the pneumonia, but there was no definition for pneumonia absorption. So in my mind, I don't know how to read a radiology report. They did show those in the study, and they looked improved to me, but again, I don't know how to read those. But this endpoint seems fairly subjective to me. And so in my mind, it could lead to a potential source of bias within the study from here as well. So in conclusion, I think this study made a lot of good points. They have some data, some statistics, descriptive at least, that show a trend towards being useful. And so this tocilizumab 400 milligrams one-time dose did show trends of being helpful in these patients as far as fever, as far as CRP levels, and O2 saturation. Unfortunately, I don't think that this study is very generalizable, and we can't make any claims off the information that we see here. Because again, there was no control. It's really hard to say that any of this data here was for sure due to the tocilizumab dosing. And not due to something else that was performed in the study. or at that hospital at the time. And so I think it gives us a lot of good ideas for future studies. And as you can see or have seen, there are a lot of studies that are going to be coming out, and I'm excited for those. But unfortunately, this is the only data we have right now. And so I think it is good to look at and fun to see where this might go. But until we have future studies, it doesn't give us too much information to go off of. And I wrote down, because this was just a recording, nobody else is actually in the meeting, I did write down some of the questions I had the first time, and so I kind of like to read those out just if anybody does have any questions. So we got a question about, have I seen anything or did they mention steroid use in this study? If we go back to the standard of therapy, they do mention steroid use, so methylprednisolone right here under their standard of care. Unfortunately, this was a pretty brief study, and so it was only about one line on their standard of care. They do not mention the frequency of steroid administration, the strengths they were using, or indication, anything about that. They just mention in this one line that they did use steroids here. To go off of this, I also pulled up the protocol that they had used, their diagnosis and treatment protocol. I read through this protocol, and I also was unable to find any solid information on steroids throughout here. This is the name of the protocol. You can always Google it. That's exactly how I found it. But I'm going to try and look through this one more time to see if there is anything on steroids, but I don't believe they did mention their steroid use. Have you heard about any other cytokine inhibitors? And I have. There are no official studies that have been published, at least that I have seen, come out since yesterday. As I mentioned, though, there are a few studies here, such as this anakinra. Anakinra is an anti-IL-1 inhibitor, and then cetuximab is an anti-IL-6 inhibitor. So they are starting to do some studies with these other anti-cytokine medications, although we don't have any data at this point. It's really just a lot of theory. And then lastly, are we routinely monitoring for IL-6 now here at Stony Brook University? And so at Stony Brook, we are. I haven't actually read the protocol for what labs they need to order, but I've been doing a lot of antibiotic audits this past week, and in almost every patient that I've audited, I'm able to find an IL-6, and so I'm pretty sure they are. We did hear from the ICU pharmacist at this point, and he confirmed that they are doing IL-6 testing routinely as part of the COVID-19 power plan that we have here at Stony Brook University. And that concludes this journal club at this time. If anyone does have any questions as they're watching this later down the road, please feel free to email me. I'd be happy to answer any questions, and I'll get back to you as soon as I can. Thank you, and I'll send out an email shortly for everybody to be able to find the link to our YouTube channel to be if you did happen to miss this. And again, if you do have any questions, feel free to email me. All right, thank you very much, and I hope everybody has a great weekend.